right. So welcome to the clinical lecture on arrhythmias. We will get right into it. Um, this lecture series, or mainly one lecture, covers the details around the clinical management of arrhythmias, and we'll go into the most common type of arrhythmia that is seen in clinical practice, which is atrial fibrillation or AFib. Um, so there's some objectives that we'll go through, that being go through review of an electrocardiogram or EKG. Both abbreviations are used to describe normal sinus rhythm. We'll go through the common QT prolonging medications and other associated risks for a life-threatening arrhythmia, which is called Torsades stay points. We will compare and contrast the efficacy and safety and monitoring of antiarrhythmic medications. Just as a heads up, there are several medications, but again, the goal is to identify or be comfortable with the ones that are more commonly used. So I will be sure to orient you to those. And then just so that we're all on the same page, there is a must-know clinical guide that goes along with this lecture. So just in case you're like, I don't know how to direct my studying, I would recommend making sure that you're comfortable with everything that is on the guide, and then you should be in good shape for my portion of the exam. We'll go through the goals of therapy for atrial fibrillation, classify the type of atrial fibrillation. There's like different subsets, and then go through the different risk factors for development of AFib. Um, we'll go through the first line agents for rate control and rhythm control in the management of AFib. Assess the stroke risk in a patient with AFib using the CHADS-VASc score, and then develop a patient-centered pharmacologic treatment plan for a patient with AFib. Um, in terms of the CHADS-VASc score, there is a slight update, not quite reflected in the American guidelines, but something that the European guidelines have done, which once we'll get to that, I will identify that further, but just to make you aware ahead of time. All right, this is just as an FYI, but everything that you need to know is within the lecture slides. So getting right into it, just to define arrhythmias, arrhythmia is an abnormal heart rhythm, which can cause the heart to beat too slowly or too rapidly or erratically. So too slowly, bradycardia, too rapidly, tachycardia, or erratically, which is just sort of all over the place with extreme fluctuations. Any disruption in the normal sequence of conduction can result in a cardiac arrhythmia, which could lead to the following abnormalities: automaticity, triggered activity, reentrant circuits, conduction blocks. So those are just further complications that can result as a result of arrhythmias. And they are classified by heart rate. So tachycardia or arrhythmia, it's with a heart rate of greater than 100. Bradycardia or bradyarrhythmia, it's a heart rate of less than 60. So that goes to show again, you all should know by this point, and it's come up a little bit throughout the cardio module, that a normal heart rate is between 60 to 100 beats per minute. So those cutoffs should make sense. The arrhythmias, they can be classified by where they come from. So there's the supraventricular arrhythmias, which are right above the ventricles, and AFib is the most common form of that. And then there's the ventricular arrhythmias, which are in the ventricles, and these are life-threatening. So torsades is one that is considered life-threatening, and we look out for sources of what could potentially lead to torsades. So that's why it matters a lot. And then the others are there for your reference. Okay. A small percentage of patients will be asymptomatic. Patients won't necessarily feel any different, even if they have an abnormal heart rhythm or heart rate. The common symptoms present in patients are chest pain, palpitations, dizziness, shortness of breath, fatigue, syncope. It could be as extreme as, causing fatalities, but Those are just some things that we note in patients who come into the hospital, in my experience. And for reference, arrhythmias includes both like rate-related and rhythm-related abnormalities. So when I had just said abnormal heart rate or abnormal heart rhythm, it could be either or, it could be both. So those are just some clarifications that I wanted to mention. So the EKG, ECG, both are essentially the same thing. This is a picture of the electrical activity of the heart, and it's typically over 10 seconds using electrodes. And it's used to diagnose arrhythmias after assessment of a patient's clinical history and physical exam. So you all may have, seen a EKG or ECG strip, and I'll get to that eventually. These are just some things that now exist, or like some devices that keep track of an EKG, ECG. The Apple Watch now keeps track of it, for those of you who have one. So that is pretty cool. It can keep, keep tabs on if someone develops or if someone has an arrhythmia. So, um, so basic interpretation of an ECG. So this is what the strip looks like in a normal patient, and the aspects of like the normal EKG, it's broken down. So you can see there's like the P wave, the PR interval, QRS complex, ST segment, and the T wave. And they all symbolize or indicate a particular part of the cardiac action potential. For clinical purposes, I'm not going to go too much in detail with this, but this is just to set the background and tone for understanding where all of the different agents work. So that's why this is important, just, to set the tone for that. Um, just to go through some of the normal aspects of a normal EKG, you'll see a ventricular rate of 60 to 100 beats per minute, which is what we reviewed. The rhythm regularity, it will be identified as regular, as in equal distances between the RR interval, P wave, QRS, T wave present, and they look the same in each cardiac cycle. So you can see at the strip at the bottom, and it's pretty like uniform. The P waves, they present if the rhythm originates in the SA node. They should be upright, identical, and right before the QRS complex. And then the PR interval, 0.12 to zero point 0.2 seconds. QRS complexes are narrow. They are 0.12 seconds or less. And then the QT interval, which is 440 milliseconds. Now, of all these facts and pieces of information, I would say knowing that what the QT interval normally looks like would be important, because this is commonly done in clinical practice. Whenever I am reviewing the EKG results, I do keep tabs on what the QT interval or QTC reading looks like. So if it is 440 or less for women, and then 460 or less for men, then that's considered okay. Anytime where it starts to get close to 500 or higher is where we get concerned with medications that could be causing QT prolongation. And we worry about, again, the risk of our life-threatening arrhythmia, which is typically torsades. So we don't want the patient to go into that sort of an arrhythmia, which I'll get to. So just to, preface that a little bit, but everything else is more like, it's good to know information. And if you need to know anything specific, I'll be sure that it's on the guide for you. And then here are just some EKG strips. You can look at how normal sinus rhythm looks relative to an arrhythmia, relative to bradycardia. So bradycardia, because that's like a slower heart rate, they are more spaced out. Tachycardia are more closely together. So the spacing is even for both, however. So you can see that's pretty like, consistent, but it's just that, the spacing out is what you can note to be different. And then for AFib, you can see an irregular baseline. The ventricular response is irregular as well. So irregularly irregular is the description for AFib. And then ventricular fibrillation, which is considered a life-threatening type of arrhythmia. You can see rapid, wide, irregular complexes, which have literally no shape or form. So it's very, very like chaotic. Um, so this is just an understanding slide. You can work through this just to kind of understand the information we've covered so far, but I'll keep it moving for the sake of time. All right, so to review QT prolongation and torsades, which is something I've referred to a little bit already, the QT interval is measured from the beginning of the QRS complex to the end of the T wave on an EKG, which reflects ventricular depolarization and repolarization. Um, the calculation is for your reference. You do not have to calculate what the QTC will be for the exam. You will not have to memorize this or be accountable for this just because it's not clinically useful. It's not something that we commonly do. EKG reports just straight tell you what the QTC is, so you won't have to worry about that. So as I mentioned a little bit before, prolonged QTC in males is above 440 milliseconds, and for females, it's above 460 milliseconds. Some food for thought is to think why it's a little different for males and for females. Not something that you have to be accountable for, but just something that perhaps you can look into. And then I mentioned briefly before, QTC of greater than 500 is what significantly increases the risk for torsades. And that's, again, something that we want to avoid. Okay, so prolongation of the QTC, this is a risk factor, which is a particularly lethal ventricular tachyarrhythmia, and this can cause sudden cardiac death. Um, and torsades, this term specifically, it's like a French term for twisting of the points. There is one drug that helps to manage this, and it's a very simple drug. It's an electrolyte, magnesium. So we give magnesium IV. We give 1 to 2 grams of it. That is pushed, which means like given all at once. So that is the treatment of choice, and that's what you should definitely remember. And as you can see, the EKG strip at the end, it looks very scary, just because it looks extremely chaotic and abnormal. Okay, so risk factors. So as for patient-specific risk factors, those are, that being like a patient just by default having prolonged QT or QTC. The female gender predisposes patients sometimes to having a prolonged QT, underlying cardiac disease, renal hepatic impairment, hypokalemia and hypomagnesemia, which are these are extremely modifiable risk factors, the hypokalemia and hypomagnesemia. So if a patient comes into the hospital and they have low potassium and low magnesium, our first and foremost priority is to make sure that we replete them and make sure that their potassium is within normal range and their magnesium is within normal range, just to avoid the risk of them developing an arrhythmia, torsades particularly. And then medication risk factors. So higher doses could lead to more of a risk because oftentimes drugs are concentration dependent, or, that's what leads to the outcome of torsades. A patient having multiple QT prolonging drugs could do this as well. And then drug-drug interactions that could decrease the clearance of QT prolonging drugs. So these are some things to keep in mind, and this is extremely clinically important. So I would familiarize yourselves with these risk factors. Here is a table with medications that prolong QT, and there's a lot. So you all, I mean, Naplex it seems like it's far away. It's not that far away. When you get there, you will see that there is like, dedicated tables, charts, things of that sort to give you a sense of how drug classes and like medications, they prolong the QTC. And those are used interchangeably, by the way. Yeah, so just I'm going to use both interchangeably, but both imply the same thing. Um, so there's medications that you see that are it's ironic. Class one and class three antiarrhythmics, which we'll get into, they can be pro-arrhythmic even though they are antiarrhythmics. So it doesn't quite make sense, but they can prolong QT. There are certain CNS medications that can do that. There's also antipsychotics, the antibiotics, antifungals. HIV drugs are commonly known to do so. Ondansetron as an antiemetic, and then methadone, donepezil. These are just, to name a few. There's so many. The ones that I have put in red, I think those are the ones that you ought to focus on as you prepare for the exam. So those are the ones that you'll probably see. And then, yeah, that's pretty much as far as the torsades and QT prolongation aspect of just arrhythmias go. So getting right into it, these are our getting started with the just introduction of the different antiarrhythmics. So as you can see, there are a lot of medications. We have four classes. There's class one, class two, class three, class four. The class one agents are sodium channel blockers, and I'm sure you've covered the pharmacology or the science behind how each of these mechanistically work. Class two are beta blockers, which you already are familiar with. So beta blockers are a class that you've seen throughout the course of the cardio module. Class three are potassium channel blockers, and then class four are calcium channel blockers, which you've also heard of, in aspects of like avoiding in heart failure and something that, technically calcium channel blockers are available as for like the dihydropyridine calcium channel blockers are available for hypertension management, but we don't really use the non-dihydropyridine calcium channel blockers except for managing arrhythmias. And if we manage them in arrhythmias, we can also use that as management for hypertension. So that is something to, as a bonus. But again, I'll go through the details of what you ought to keep straight. On the side, you can see this like mnemonic, double quarter pounder, lettuce mayo, fries please, because dieting during stress is always very difficult. This is to keep track of pretty much all of the antiarrhythmics. This is a mnemonic that is, I believe, in the U World book for NAPLEX studying. So you'll probably come across these, but I'll be very honest. I don't see all of these in clinical practice. They are on the market. But as far as like how often we're seeing each and every one, that doesn't happen. So some of this stuff I'm just going to breeze over, and if it's in your study guide, review it, know it, study it. But if it's not, then it's just more FYI. So just to break down class one a little bit, as you can see here, there's subclasses. There's 1A, 1B, 1C, based on how their onset or not duration of action is rather. So there's the intermediate acting, there's the fast acting, and then there's the long acting. Um, so they, are used for different purposes because of that. So getting right into it. Um, the use of class one and three antiarrhythmics it has declined because a lot of clinical trials have shown increased mortality with their use in several situations, realization of their pro-arrhythmic potential, and advancing technology of non-drug therapy such as ablation and ICD pacemaker placement. Um, so there are a number of medications in the class one class that I can definitely see that for. Class three, I will go into ones that we still commonly use. So there's just some, key takeaways with that. But just to make you aware, there are several that we just, steer clear from. Here's a table that breaks down the medication and then the clinical considerations. So again, this table, I would say like review and make note of whatever you need to make note of if it's on the guide. If it's not on the guide, then, just kind of, we'll kind of go through it as more of like an FYI thing. So class 1A, you can see there's disopyramide. The main thing that we ought to consider is it can cause anticholinergic side effects. Quinidine is one known to cause like ringing in the ears sort of sensation, which is called synchonism. I don't even know how to say that. Tinnitus, hearing loss, blurred vision, headache, delirium. It can also cause hemolysis risk, so ought to be avoided in G6PD deficiency. There's procainamide, which can cause lupus, drug-induced lupus, and it can also cause blood dyscrasias. So those are some things unique to it. And then you can see the rest of them just kind of there for you for your reference. And again, if there's something specific that I would like for you to know, then I will be sure to indicate it on the guide. And then class 3 antiarrhythmics. So the ones that I've commonly seen in practice are probably dofetilide and amiodarone. Amiodarone ex is extremely, extremely, extremely common. Um, we see that one the most out of all of these. These other ones are technically available, but very unique circumstances in which they come into play. So just to go through these a little bit, dofetilide, it needs to be initiated in the hospital because the EKG can have abrupt changes and it can also affect or t be tied to renal function. So look out for changes to that for a minimum of 3 days. We have to look out for renal dose adjustment with dofetilide use, and it is one of two agents that is safe for use in heart failure, which is why it's more commonly used. So either dofetilide or amiodarone are both considered safe for use in underlying heart failure, and that's the key benefit. These other ones cannot. So dronedarone, sotalol, ibutylide, those are ones that we do not go to if patient has underlying heart failure. So dofetilide, as you can see, the main thing with it is renal function and looking out for patients who have underlying renal disease. If they do, then perhaps we would lean towards amiodarone. We'll go through the details of that later in the lecture. It can be used again for heart failure, but there's a number of monitoring that we do for it, and you all ought to be somewhat familiar with it from top 200 because it comes up. So we do pulmonary function tests because there are pulmonary concerns that can arise with amiodarone use, liver function test monitoring, and then thyroid function test monitoring. So all these things we look out for with amiodarone use because it can make those worse. So if that's the case, then that's where we would bounce to dofetilide. So that's kind of where our tendencies go, but more to come. And then just to answer this, which of the following regarding torsades is false? So A, QTC of greater than 500 significantly increases the risk for developing torsades. Hopefully you identify this as true. The treatment of choice for torsades is potassium chloride, 40 milliequivalents IV push. That is incorrect. The treatment is magnesium sulfate, 1 to 2 grams. IV push. So not potassium, rather magnesium is the treatment of choice. And then the rest are true. Hypokalemia and hypomagnesemia are important risk factors, which are modifiable risk factors. If we correct the potassium and correct the magnesium, then that would be, ensuring that the patient isn't at risk. And just to indicate like the normal levels, so hypokalemia, as long as we have the patient's potassium above 4, and for magnesium, if we replete their level to above 2. So that's a common inpatient goal for patients. We, aim for a potassium of greater than 4 and aim for a magnesium greater than 2. Numerous medications may increase the risk of torsades due to QTC prolongation. That is absolutely true. So again, B is the right answer here because it's looking for the false statement. Okay, and then you can see here, just in terms of matching, something that you can aim to do on your own time, more practice. So this patient is a 52-year-old with paroxysmal AFib, hypertension, dyslipidemia, presents to the pharmacy complaining of ringing in his ears, blurred vision, and confusion. So you may vaguely remember quinidine is the one that causes the ringing sensation, the synchronism. I can't even say it. But yeah, ringing in his ears is the sensation called tinnitus. So that's what you would group that or identify that as. Okay, getting into the most common type of arrhythmia, which is atrial fibrillation. This is very important to be familiar with. So most common sustained cardiac arrhythmia. The background of it is there's the atria, they fibrillate, which cause disorganized electrical activity and ventricular contraction. They do not fully empty. The atria do not fully empty, causing blood pooling. This could increase the risk for thrombus formation, which could lead to the formation or the development of a stroke. So essentially, the blood pools, clot forms, clot could potentially travel to the brain and cause a stroke. Um, Fibrillation of the atria may cause the ventricles to beat very fast, which we call rapid ventricular response or AFib with RVR. This leads to an ineffective pump function of the heart, which could cause or worsen underlying heart failure. So that could be of a concern. So as far as EKG findings go, we can see irregular. So the RR interval follows no repetitive pattern and is variable. And then the P waves are absent, not discrete, and they're replaced by fibrillation F waves. So irregularly irregular is the description. And then here are the classifications for the different types of AFib. So there's the paroxysmal, then there's the persistent, long-standing, permanent, and valvular. And they all are unique in their own way. Paroxysmal being one that occurs sometimes and then stops on its own without intervention. The heart returns to normal sinus rhythm within 7 days of onset, and the episodes may recur with variable frequency. Persistent AFib is one that does not stop on its own and is sustained greater than 7 days, but can be cardioverted. Long-standing persistent AFib is one that is greater than 12 months. Permanent AFib is one that is used when the patient and clinician make a joint decision to stop further attempts to restore and or maintain sinus rhythm. And valvular, lastly, is one with moderate to severe mitral stenosis or with a mechanical heart valve. So long-term anticoagulation with warfarin would be indicated in that case. So you can see these are all unique in their own way. And again, I would review whatever is according to the guide that I provide to you. Risk factors. So, the non-modifiable, as you can see, would be age, male gender, cardiac diseases to some degree. You can't really modify them because they are progressive, and once they are diagnosed, you can get them under control as best as you can. But, they are, in fact, at this point, part of the medical history, that being heart failure, myocardial infarction history, hypertension, valvular disease. Obesity is a modifiable risk factor, right? Hyperthyroidism, something that can be also medically managed. Stressors, that being physical exertion, surgery, sepsis, and then usage of certain drugs, alcohol and caffeine particularly. So also a modifiable thing. So not clearly, identified here, but I would go through and make sure you can identify like what you can fix or adjust versus what you can't. Okay, so symptoms, patients can be asymptomatic, but then they can also have palpitations, shortness of breath, fatigue, things that like we had reviewed at the beginning. That's very much a possibility. Severe symptoms are acute heart failure exacerbation, severe hypotension, myocardial ischemia, which causes angina. So any of these could potentially happen. And then the treatment guidelines. So this also comes from the same body that the rest of the disease states came from, AHA, ACC. They are the ones who, pretty much put together the evidence-based recommendations. Okay, an understanding question. So there's, essentially a case, and you're going to use the classification table to identify what exactly this type of AFib this patient has. So this is someone who has had multiple failed attempts at cardioversion. The patient and his physician have decided to no longer attempt to achieve normal sinus rhythm and will leave the patient in AFib. So this, hopefully you identify this as permanent AFib because going back to the table right here, the term permanent AFib is used when the patient and clinician make a joint decision to stop further attempts to restore and or maintain sinus rhythm. So that is that. Okay, so now that's review of AFib. Now we will go into rate control versus rhythm control. So rate control, this focuses on controlling the ventricular rate, that being trying to get the patient's rate to be between 60 to 100. That is our ultimate goal. Achieving ventricular rate control should be a treatment goal for all patients with AFib. Rhythm control, this is the attempt to restore and maintain normal sinus rhythm. Not all patients should receive rhythm control, and restoration and maintenance of normal sinus rhythm is not guaranteed. So primarily, rate control is what we aim to do. Um, and then some pivotal trials, that being Affirm and Race trials, which at the bottom, the details you can see there, more FYI. These compared rate control to rhythm control, and they didn't find any mortality benefit with rhythm control. So it didn't prolong life just with managing rhythm on top of rate. In fact, the rate of hospitalization was higher in the rhythm control group. So that is that. So first line for rate control are beta blockers, which excellent agents for this. And beta blockers, as you can tell by at this point, now that we're nearing the end of the cardio module, they're used for numerous purposes. But when it comes to arrhythmias, comes to AFib, we refer to or go to beta blockers if we, as long as there are no contraindications. And then if we can't use a beta blocker for whatever reason, then we have our non-dihydropyridine calcium channel blockers, either diltiazem or verapamil. They should not be used in heart failure with reduced ejection fraction. Hopefully you all remember that. It's okay to use in preserved, but with using in reduced ejection fraction, again, it's the risk for causing further worsening heart contractions. So we want to avoid in that particular subset. And then alternatives, we have digoxin, which is a potential option. And you may vaguely remember it's part of heart failure management, but it's not something that is considered first line by any means. There's potential use of it for helping to reduce hospitalizations, but it doesn't have any mortality benefit. So kind of similar with management of arrhythmias or management in AFib. We don't really resort to digoxin all that frequently, but it is available on the market. Okay, so the exact heart rate goals, I know I'd mentioned trying to get the patient's heart rate between 60 to 100. So I wanted to clarify that in patients with an underlying arrhythmia, particularly for AFib, I should just say AFib at this point, we have a very specific heart rate goal. So for patients, as you can see, a goal resting heart rate of less than 80 beats per minute in patients who have symptomatic atrial fibrillation, or those with left ventricular dysfunction with an EF of 40% or less, which is our patients with heart failure with reduced ejection fraction, essentially. Okay, so this is an or thing where either symptoms or heart failure with reduced ejection fraction. And then with patients who are asymptomatic, and the key word there is and, both conditions have to be true. they have preserved left ventricular function, so an EF of greater than 40%. For those patients, we aim for a heart rate of less than 110. And again, this is evidence driven in terms of the outcomes that we see based on these heart rate goals. It's just more promising for us to aim for these particular goals. So that's, kind of what drives this. Being more stringent in patients who have symptoms or have underlying heart failure with reduced ejection fraction is going to lead to better outcomes. And then those patients who aren't presenting with as extreme of a picture, meaning they are not symptomatic and they don't have underlying heart failure, or their ejection fraction isn't low. For them, we don't have to be as narrow with our approach, if that makes sense. So these goals are important. They will definitely be on the guide. I can tell you that right now. Okay. As for the common dosing, so this is more as an FYI. This will not be on the exam. It may potentially be on just like, case practices and things like that, but not something that you will see on the exam. So you can see beta blocker common dosing as well as the non-dihydropyridine calcium channel blocker dosing. Um, and yeah, just more so as an FYI. And then digoxin, just for the sake of completeness. So this is considered adjunct, used as, just something that we add on top of a patient getting a beta blocker plus a calcium channel blocker. It's used, it's fine for use in patients with heart failure. So in the situation, for example, that a patient's on a beta blocker in heart failure, they still have an abnormal or increased heart rate, then we would add on probably digoxin for them instead of our non-dihydropyridine calcium channel blocker, because those are contraindicated or to be avoided in heart failure with reduced ejection fraction. Like we wouldn't want to use those, so we would probably opt for digoxin on top of our beta blocker. Um, and then in terms of the onset of action for digoxin, it's over 1 hour, half-life 36 hours, so not recommended for acute immediate rate control. Beta blockers are our go-to, and also our non-dihydropyridine calcium channel blockers. They work very quickly. So that's one downside to using digoxin. And then you can see the dosing here, more so FYI. When the creatinine clearance is less than 50 milliliters per minute, then we would reduce the dose or frequency. And then when converting from PO to IV, something unique about this is that the dose needs to be reduced by 20 to 25%. So that is something to factor. And then as far as levels go, so the serum concentration for digoxin, we aim for between zero point 0.8 to 2. Just to clarify this actually, and I'll probably have to issue an announcement, but the exact therapeutic window is now considered to be zero point 0.8 to 1.2, not 2, 1.2. So something to keep in mind with that. For heart failure, the range is a little bit lower. So that is a unique difference between heart failure digoxin use and AFib digoxin use. For heart failure, we do zero point 0.5 to zero point 0.9, and then for AFib, zero point 0.8 to 1.2. It's important to correct any electrolyte abnormalities, low potassium, low magnesium. Again, potassium above 4, a magnesium level of above 2, and hypercalcemia associated with risk for toxicity. Digoxin has a number of drug-drug interactions, that being with amiodarone, dronedarone, verapamil and diltiazem. And then you can see here just some potential side effects, which there are many. So GI disturbances, visual changes, neurologic manifestations, just to name a few. And then if we ever need to reverse the effects of digoxin, we do have an antidote available, that being digoxin immune fab or digifab. So that is something that can be used if needed. Another understanding question. So we have a patient with a past medical history of heart failure with reduced ejection fraction, who has recently been initiated on carvedilol for rate control of his atrial fibrillation. JR's heart rate today is 115 beats per minute. JR is not currently experiencing any symptoms of AFib. So what is the heart rate goal for this patient? So hopefully you arrive to the answer of less than 80 beats per minute. And that is because, again, patient's heart failure with reduced ejection fraction, so their EF is less than 30 or less than 40%. Less than or equal to 40% is the cutoff. And this patient has an EF of less than 35%. So our goal is less than 80 in such patients. This particular slide highlights that for you. Okay, moving right along. Okay, and here's the patient. This is a little bit of math practice, which I'm gonna let you do this, and if you have any questions, just let me know. But you basically have a conversion from PO to IV digoxin, and you have to keep in mind again that there's a 20 to 25% reduction that you have to do when converting to IV because the IV form is more bioavailable, right? So just making sure that you account for that in the final answer. And that is something that, again, I recommend you practice this. And if you don't arrive to a clear answer, you're not sure, then please, please, please let me know. Okay, and then rhythm control. So this is a goal to restore and maintain normal sinus rhythm. The patients who benefit or may potentially benefit from rhythm control are those with an initial episode of AFib, if they have persistently symptomatic episodes despite rate control, those who are younger, and patients who have structural heart disease or heart failure. We, may potentially need to use a rhythm control agent. That being the antiarrhythmics that I reviewed briefly before. Conversion to normal sinus rhythm. So we sometimes have to opt for direct current cardioversion or pharmacologic agents, which, again, there's the medical management or there's the cardioversion management, which is using the current to shock their heart basically back into rhythm. Maintenance of normal sinus rhythm includes pharmacologic agents, catheter ablation, and then if AFib is permanent, then we avoid rhythm control antiarrhythmic drugs just because the risk is more than the benefit. So direct current cardioversion, it entails, again, as I briefly mentioned, like a high energy shock through the chest wall, which shocks the heart back into normal rhythm. And it's successful 80 to 90% of the time, but requires, it's a procedure. So it would require sedation, anesthesia, all that. This shock breaks the incorrect cycle, stops the arrhythmia, allows the sinus node to begin firing again with the normal sinus rhythm. So you can see at the bottom the EKG strip going from abnormal to normal. Um, and then pharmacologic cardioversion, meaning basically using drugs to get the patient back to normal sinus. It has a relatively lower success rate, most effective when administered within 7 days of AFib onset. And you can see here class 1C and 3 antiarrhythmics are the ones that are opted for, but I haven't really seen 1C as frequently. The reason is because a lot of times these patients have underlying structural heart disease. So as you can see, flecainide and propafenone, which are in class C, these are to be avoided in patients with structural heart disease. Like that's a no-no. Of class 3, we have dofetilide and amiodarone, which are the ones that I pointed out earlier. Those are the only agents that are safe for use in patients with structural heart disease or heart failure with reduced ejection fraction. Um, and then I mentioned briefly before, but just to reiterate, dofetilide requires inpatient initiation and renal function monitoring very closely. We have sotalol and dronedarone. These can only be used for maintenance of normal sinus rhythm after the initial cardioversion. So there's a lot of like unique characteristics to each, but I think the key takeaway that you all should understand here is knowing the role of dofetilide, amiodarone, knowing that class 1C, this, the reason why those are to be avoided is in underlying structural heart disease. So just kind of like the agents that are mentioned here and what's highlighted here is what you ought to focus on. If anything is still unclear, then definitely let me know and I'll be more than happy to clarify. And again, I've said this multiple times. My guide will ensure that you focus on the things that you need to in order to prepare for the exam. All right, amiodarone. So this is very important, very, very, very important. The details with amiodarone are many. There's a lot of things to keep straight. So you can see this agent has a super, super, super long half-life. We're talking 40 to 60 days. For that reason, it can accumulate in the body tissues and potentially cause side effects and other toxicities, which I'll get to. Some common side effects are low blood pressure, causing low heart rate, which kind of makes sense. The thing with this antiarrhythmic is it does have heart rate lowering effects. So it doesn't only work on reducing or normalizing heart rhythm, it can also work on reducing the heart rate a little bit. Um, there's also dizziness, tremor, photosensitivity. It can cause this like blue skin discoloration, which I have seen in clinical practice before, and it's actually quite scary. Potential toxicities, so the ones that I highlighted before, and just to reiterate, thyroid dysfunction, pulmonary fibrosis, hepatotoxicity. These are the key ones that you need to really, really, really know like the back of your hand. That amiodarone can mess with these disorders. If a patient has underlying concerns tied to these things, then that's why we, keep an eye on the function test pertaining to that, organ system. And then there's a number of drug-drug interactions, CYP3A4, 2C8, PGP, 2C9, 3A4, 2D6. There's just so many drug-drug interactions. The ones that you ought to remember, so knowing warfarin, digoxin, statins, and again, this is hopefully review from top 200 that when you start amiodarone and if a patient has digoxin as part of their medication regimen or warfarin. I think I've asked like a warfarin related question, like where warfarin and amiodarone are together, you would reduce the warfarin dose by 30 to 50% empirically. If the patient is on amiodarone or rather already on digoxin, you start them on amiodarone, then you decrease the dose of digoxin by 30 to 50%. So that's a key clinical consideration and something that we, automatically would do. And then while I'm on amiodarone, the maximum dose of the different statins are there for your reference. You do not have to worry about those. I would say, like, again, looking at what's in red here is what's key. So looking at, again, the empiric dose reduction, the medications that could potentially interact, and then potential toxicities, again, thyroid dysfunction, pulmonary dysfunction, hepatotoxicity, or liver dysfunction. Looking out for those is key. Okay, and then this is just a review of the monitoring that we do with Amio. So looking at the parameters and then how often they are to be monitored. So for the most part, on an annual basis, thyroid function tests are every 3 to 6 months. Ophthalmic examination is if there's something that happens to prompt us to check for it. And then liver function tests would be every 6 months. So yeah, this is more so just to, give you a sense of how often we're keeping tabs. And then in terms of our rhythm control maintenance, so you can see structural heart disease is at the very top. And then based off of that, we go towards either pharmacologic management or we go towards catheter ablation, which helps to maintain the patient in normal sinus rhythm. Um, and this is again just kind of an overview picture, and we'll get into the details, but Yeah, this just gives you an overview. Catheter ablation may be considered first line for patients with paroxysmal AFib only. So that's key to be aware of. So this is a procedure that scars or destroys the tissue in the heart that's causing inappropriate electrical signals to create abnormal heart rhythms. This is in a special hospital room called an EP lab or electrophysiology lab. It can even happen in the cath lab, which is where you may remember that's where stent placement takes place, or where, like, percutaneous coronary intervention, PCI, for patients with ischemic heart disease or acute coronary syndromes, things like that. This is a reasonable option for patients who remain symptomatic despite drug therapy or as an alternative to long-term antiarrhythmic medication treatment. Okay. Major toxicities of amiodarone, real quick: pulmonary, liver, and thyroid. So you should just be able to name them right off the bat. Um, and then if the patient has the second scenario, PK takes digoxin 0.25 milligrams once daily for rate control of AFib. PK is being initiated on amiodarone today to attempt to achieve rhythm control. So in terms of his digoxin dose, when starting amiodarone, we want to reduce this by 30 to 50%. So you would drop the dose down to 0.125, which is exactly half, or whatever the 30% value would be. But 0.125 is what is commercially available, or something that we can practically do. So that's what I would opt for. Okay, so we've been moving very quickly through everything. And again, if anything is unclear or you would like to clarify anything at all, then definitely, definitely, definitely reach out. So now on to stroke prevention, which you all may remember when we were reviewing AFib. So this is an independent risk factor for stroke. When there is blood pooling that occurs and that could cause like a thrombus to form, that can be ejected from the heart and block arteries in the brain that could lead to a stroke. So that's why long-term anticoagulation may need to be considered for patients with AFib. And we'll go through the scoring criteria for how you determine if a patient is a candidate for anticoagulation or not. Um, Patients who are undergoing rhythm control strategies via cardioversion should receive short-term anticoagulation, and we'll get to the details of that. But yes, anticoagulation is part of AFib management also. So this is an overview of cardioversion and anticoagulation. Prior to converting a patient to normal sinus, patients should be assessed for the need for anticoagulation based on the duration of AFib. So if the duration has been less than 48 hours, then you would start anticoagulation immediately and proceed with cardioversion. If it's been greater than 48 hours or unknown duration, then you would start the anticoagulation for at least 3 weeks before undergoing cardioversion, or you would get a TEE, which is a scan to rule out the formation of a thrombus. Um, so that's how the different types are approached. And again, the timing is what matters here. All patients who are cardioverted should continue anticoagulation for a minimum of 4 weeks after they are cardioverted. And then long-term anticoagulation decisions are made based on the patient's CHA2DS2-VASc score. So that's what I was getting to. We use this score to determine if a patient is a candidate or not. So this is the CHA2DS2-VASc score. You can see factors for heart failure, hypertension, age, diabetes, stroke, TIA, thromboembolism, like a prior episode of that, vascular disease, and then gender. So there's a point automatically assigned for the female gender. You can see that a score of 2 or more for men or 3 or more for women is when we would start oral anticoagulation. And these are the agents that you already covered with Dr. Hall, are DOACs, or potentially warfarin, but DOACs are preferred. I will provide the CHA2DS2-VASc score for you. Like, you will have this available as you say like you have a practice, case or something that is on the exam, then you will be provided this criteria. So the key task that you'll have is to be able to just, sum up all the points, and then based off of that sum, decide whether the patient is a candidate for anticoagulation or not. Okay. So this is the update, which I think I mentioned towards the beginning. We have the European Society of Cardiology. They removed the gender category, and it's expected to be removed in the upcoming ACCHA guidelines as well. So this is an expected change that may potentially happen. They just found that the female gender being part of the scoring criteria isn't necessarily something that they have to account for. So because of that, that is something that, maybe the case. So their new scoring system, it's basically called CHADS-VA. So they've gotten rid of the SC at the end. Very interesting. But for now, I guess to wrap the thoughts up on this, for now, we still account for the genders, like accounting for females, give them a point for that. The Hasbloods score. So this estimates the bleeding risk, and what this scoring criteria is used as is weighing what the patient's risk for clotting is, which is the CHADS-VASc score, and what their risk for bleeding is. So sometimes we look at both, and then based on our findings, we just kind of weigh, okay, this patient's CHADS-VASc score is high, so their clotting risk is high. And then sometimes their Hasbloods score seems to be high, so then we're worried about the risk for bleeding in such cases. So it just kind of depends like how we approach either or. Um, but yeah, that's kind of, just also criteria that if you ever need to calculate the score for, you will be provided exactly the criteria for it. You just have to sum it up and then be able to just determine like what the next steps would be. There is no interpretation for this. Now, not every scenario would call for using the Hasbloods criteria. So if in the situation that I give you a case, then I will tell you like this score implies like, a cutoff of this means this. Like you will be given the specific guidelines for what the score implies. So just to clarify that. Think that's all I had. Oh, and then another thing that I want to make sure to reiterate. CHADS-VASc and Hasbloods, these are criteria only used for the condition of AFib, meaning they are not used across the conditions of venous thromboembolism, VTE. We do not use these scoring criteria for an actual formation of a clot. At that point, the patient does need to be anticoagulated. So there's no scoring or weighing like whether this patient is a candidate or not. It's only for the condition of AFib where we would use these scoring criteria. I hope that that's as clear as possible. Okay. And then we have our anticoagulation options, which again, Dr. Hall hopefully reviewed these already in depth with you all. We have our direct oral anticoagulants or DOACs, which are first line, and then our alternative would be warfarin. So that is that. Warfarin is cheaper relative to our DOACs, but it does require in-clinic monitoring of the INR, and it is, yeah, just in terms of the upkeep with it, it can just be a little bit more cumbersome. So that is the problem. And then it has a narrow therapeutic window, as you can see. So 2 to 3 normally. If a patient has a mechanical mitral valve replacement, then their INR goal is 2.5 to 3.5. And we have to bring the patient into the clinic every time and ensure that they are where they're supposed to be. If the patient's indication is mechanical mitral valve replacement, then warfarin is kind of the only treatment of choice. Then we can't use a DOAC in that case. So that's key. This just reviews the dosing. So there are some unique things that are tied to dosing with DOACs and AFib. So I will highlight those for you. And again, we'll be sure that the guide reflects what you need to know. So dabigatran, that is a standard 150 milligrams twice a day, reduced in a creatinine clearance. Of 30 to 50. And then if they're also taking ketoconazole or dronedarone, which are considered high alert, like drug interactions. And then also creatinine clearance of 15 to 30. So like you would use 75 milligrams twice a day in such cases. And then avoid, as you can see, the details are. But I would say focus on what is in red here. So rivaroxaban. Normally we dose with 20 milligrams once a day, and it's best absorbed with food. So the counseling point with rivaroxaban is to eat with the biggest meal of the day. We would reduce the dose to 15 milligrams once a day if the creatinine clearance is less than 50. And if there's potential for drug-drug interactions, then we would avoid their use or creatinine clearance of less than 15. So that is something unique for that. Apixaban. So this is the dose adjustments and considerations are not in red here, but I'm telling you they are so important and come up in practice all the time. Apixaban is normally at 5 milligrams twice a day. Um, we would reduce the dose to 2.5 milligrams twice a day if the patient meets two or more of the following criteria. That being age 80 or greater, serum creatinine of 1.5 or greater, or if their weight is 60 kilos or less. So this criteria comes up so often. I'm telling you, if you're on rotation with me in the future, you will do practice with DOAC dosing all the time, and it's definitely going to come up for you over and over and over. You're going to need to be familiar with how to dose reduce apixaban in the indication of AFib. So again, be familiar with this criteria. Um, and then I would disregard edoxaban. I don't see it in clinical practice. It's there for your reference, but you do not need to worry about it coming up on the exam. You can see here that it is not recommended for use if the creatinine clearance is greater than 95. So essentially, normal renal function is considered to be not good for edoxaban use, which is a weird consideration. So that's why we don't really opt for it. So again, be familiar with the Pixaban and like the nuances with that, and then also rivaroxaban. Dabigatran more as an FYI because the more commonly used DOACs of the ones that you see here are Pixaban and rivaroxaban. Okay. And then the DOACs, they may not be appropriate for all patients. So the specific ones that like that for which warfarin is the only appropriate option would be if there's, say a patient prefers to come into the clinic just to feel like as if their number is within range, which is a thing. Like they just want to have that level of comfort knowing that their INR is within the read that it's supposed to be. That's something that may prompt them to opt for warfarin. Drug interactions can sometimes be a concern too. So again, a therapeutic INR can indicate like whether there needs to be or rather I should say an INR reading that is above or below indicates to us like how we need to adjust the warfarin dose. So that is something, that is a benefit of monitoring it. And then cost. Warfarin doesn't cost as much, so it's a relatively cheap drug. But the maintenance is just, being able to make it to the appointments, transportation, things like that. Those are some things that you have to factor in for whether the patient can keep up with that. And then the indications that, or like scenarios in which warfarin is kind of our preferred, would be moderate to severe mitral stenosis, mechanical heart valve replacement, end-stage renal disease, or if the patient is on dialysis. The go-tos there would be warfarin or apixaban, and apixaban is actually used pretty widely now. not really considered a problem as much anymore. But DOACs used to have just this whole renal adjustment concern and, whether we can safely use them. And you probably saw that with the tables that we went through earlier, how you have to renally adjust. Apixaban, fortunately, there's enough data to indicate that it's not considered unsafe. And then if the patient had a recent GI bleed, then apixaban is considered the relatively safer anticoagulant in that situation. Patients with AFib who are candidates for anticoagulation will continue therapy indefinitely with an annual reassessment to weigh the risk and benefit. So they don't ever stop taking it, which not sure if Dr. Hall, like I'm sure that this came up with provoked versus unprovoked VTEs. So it's a little bit different. Provoked leads to anticoagulation for at least 3 months, which is what the guidelines say. And then unprovoked, is more of an indefinite timeline just because we don't really know what the cause was. For AFib being the indication, that is also a similar concept where we don't know what the risk would be if we were to take the anticoagulation off at some point. So that's why it just continues for life. But we continue to weigh whether the risk and benefit, if that ratio looks to be pointing in a certain direction. Say, for example, the patient has a history of bleeding with the anticoagulant, then we would probably reconsider whether this is the best thing that we need to do for the patient. And then in terms of safety, so signs and symptoms of bleeding, renal function, we look out for that for DOAC specifically. INR for warfarin, also used for monitoring efficacy. So it's both for safety and efficacy. And then in the hospital, the INR is checked on a daily basis, at least weekly outpatient during initiation, and then every 4 to 12 weeks once stable. Okay, and then this is a Chad's Vasc practice case. So there's a patient with the past medical history of hypertension being initiated on anticoagulation for AFib. You see her weight, you see her serum creatinine. So looking at her details, she's 78 years old. So based off of the Chad's Vasc criteria, she gets 2 points because her age is above 75. She's a female, so she gets a point for that. She has a history of hypertension, so she gets a point for that. So those are, altogether 3 points so far. So she has 3 points, and that means that yes, as a female, she would be a candidate for anticoagulation. And then if this patient is initiated on apixaban for stroke prevention, then our dosing would be, so we've been provided a weight and a serum creatinine. So based off of this information, she has a weight that is less than 60 kilos, and she has a serum creatinine of above 1.5. And the other criteria, just for completeness, is age that is 80 or above. So she's 78, but 2 out of the 3 criteria are met. So therefore, we would go with the lower dosing, which is 2.5 milligrams twice a day. So instead of 5, we would go with 2.5. So that is the answer there. And then here are just some summary points. So we've covered so much during this lecture, a lot of details tied to everything. But again, hopefully my guide, just streamlines the information a little bit more. So an EKG, as we reviewed, is a picture of the electrical activity of the heart used to diagnose arrhythmias. Number of medications have been associated with QT prolongation and subsequent risk for torsades, including antipsychotics, antidepressants, antiemetics, and antimicrobials. Most class 1 and 3 antiarrhythmics have declined, but a lot of toxicities that require careful attention, which we reviewed. Management of AFib, the most common arrhythmia, involves rate and/or rhythm control, as well as stroke prevention. AFib can be classified as paroxysmal, persistent, permanent, and valvular, which we reviewed. Rate control is recommended for all patients with AFib, with beta blockers being the preferred agents. But after that, if those can't be used, then we have our non-dihydropyridine calcium channel blockers. Rhythm control may be achieved using direct current cardioversion or select antiarrhythmic drugs. And then the stroke risk and need for anticoagulants in patients with AFib is evaluated using the CHADS-VASc score. Direct acting oral anticoagulants are preferred for stroke prevention in AFib. Um, so that sums up mostly everything that we covered. And again, there will be a guide provided to correspond to this lecture so that you can optimally prepare for your exam. Please let me know if you have any other questions or points of concern. And that wraps up this lecture.